that a kind of fracture?
Yes.
What was the name of that? Use it. What was the name of that? You were not here, you don't know. That is the reason you don't know. What about the others? Hassane, long time no see. It's a pleasure that you have the time to come to the class. Thanks so much.
This
Thanks so much.
fracture.
I will try to reply you as soon as possible. Sorry.
Fracture greater.
Evaluation.
I know. But there's a type of evolution fracture. Don't keep it on the side. Just remember it. Evolution fracture. No need to repeat it again and again and again. Evolution fracture is easy. Evolution fracture. And when it can be happen? When you have an extra. How are you, Robbie? When you have a kind of extra tension on the muscle and tendon and bring the part of the bone with each other. Ramon. What? Noor. Noor is talking. Okay, Shah. Okay, so when you have a high level of tension and bring it part of the bone with yourself, okay? We call it evolution fracture. Thanks God. Okay, so you have the idea about this actually concept. I think probably should I put it there? Okay, good. So you see the picture very clearly. And where is what? Okay, I think you have the picture right now. Okay, this is an X-ray. You can see that this is a kind of detachment for the bone, as you can see, and it should be not just it should be greater tuberosity. Okay, where is the lesser tuberosity? There is no lesser. Doesn't have it.
No.
Where is it? Probably he doesn't have.
No.
Where is it? Inside of the bone. In an AP view, anterior posterior view, you can see the lesser tuberosity. And what was the work of lesser tuberosity? What is the attachment of the lesser tuberosity? Do you remember? Subscapularis. And what was the role of the subscapularis? Internal rotator. Easy. Very easy. Okay, good. You have all of that. You can see the detachment. You can see the detachment. It's a kind of fracture. And is it new or not? Is it new or not? Tabarek. Is it new or not? Rogaya, here. Is it new or not? The fracture. After healing. Is it new? How can you understand? How can you find it? With some kind of magic. With some kind of magic. Or probably a kind of gamble. Lion or line. Yeah, something like that. How can we find it? This is new or not? Come on, Noor. Come on. Brainstorm. It's brain turbulence, not a storm. It's brain turbulence. Okay. How can we find it new? What is the characteristic of a new fracture?
An open the bone. This closed. يعني بعد after healing this.
It's not new. It takes time, probably 3 weeks, something.
Yes.
But how can I understand it? When you see the picture, you got the point. It helps your treatment plan. It's not just for the fun. You want to get the information from the X-ray or the evaluation of the patient. How can we find it? Okay, in a new fracture, you have sharpness. You know the meaning of sharpness? You have sharp edge. You can see the sharp edge. Why? Osteoclasts come to the area, remove the sharp area and bring it round. You do remember? Osteoclasts.
Yes.
Okay. What about the cortical bridge? Third cortical bridge. It takes about 2 weeks up to 3 weeks. Mostly 3 weeks. So this is not a kind of blank area. This is not a kind of actually completely black area. I mean looser density. You can see there is a lower density, but there is something between two parts of the fragment. So it's not new. You have the cortical bridging. Is it a kind of jump? After 3 weeks, we have a kind of cortical bridging with a jump. We can't see anything before. You say today. You're absent. You were absent. Yes? Forget your name. Maria? No. Rohaya, second. Another Rohaya. Okay, so that means when you see a kind of density at the place of the fracture, so it's a kind of actually old fracture. It's a kind of old fracture. It's not new. Because there is a density and it takes time. You are expecting it, everything is normal. It should be, because there is no detachment so much. The distance is not so much. And the alignment of the bone are good. So there is no angulation. Angulation, you know the meaning of angulation.
Yes.
Okay, so everything gonna be okay. So I think that everything is fine and there is cortical bridging. If I want to say that second cortical bridging or third cortical bridging, we are looking for the third cortical bridging. This is the quality of the picture. You cannot understand the third and fourth or probably second right now. You will get it after the radiology course. It's okay, but it's not empty, it's not blank, it's not black. Okay, so that was the reason we passed the stages of the healing, and it's part of the cortical bridging, second one or third one or anything. So this is not new. So what does change when you see that this is not new? You can be confident that the stability is good. After a little way, after you be confident you have third cortical bridging, after a little, probably 1 week at most, or 3 days, 4 days, something like that, you are able to provide or progress your exercises or range of motion or your plan of the treatment. I cannot understand without checking it. So, if you don't check it, you may consider a kind of, how can I say, kind of disaster. You didn't reach the third cortical bridging, and you want to move the extremity. So what is happening? Pain, discomfort, lower function, swelling, and mostly no movement because of the pain. The patient keeps the hand, doesn't let you to touch it. Okay, so it's very important to be confident about the structure of the bone. Okay, it's very good. So you see that this is a scan, CT scan, and also it's another X-ray, and you can see partially lesser tuberosity here and lesser tuberosity here. So it's a kind of anterior posterior AP. Probably yes, with a kind of external rotator. How can you understand this is a kind of external rotation? Because you can see the tuberosity, lesser tuberosity. So in AP view, you can see the lesser tuberosity. Right now, I can see the lesser tuberosity. So this detach, again, what was the name? Fracture? Evolution fracture. So you have a kind of high intensity on the muscle to attach this actually area. So scapulars. Okay, so one more point. If you are considering with evolution fracture, is it possible to provide a kind of stability without any kind of ORIF? It's very hard, very hard. Because any kind of tension detach again the part of the bone. So what's happening?
Stability.
Again, instability. Again, come back to the initial step. So it's very hard. Probably the best way for any kind of evolution fracture is using some simple ORIF, such as simple ORIF. Just one screw, two screw, or wire. Okay, you can keep it on the place. Okay, good. Any questions? Everything is clear? Good job. Okay, this is another picture, and you can see the bicipital groove, lesser tuberosity and greater tuberosity. This is lesser tuberosity. Sometimes you have a kind of force in the nerve or artery who are in the bicipital groove, and probably going to be a kind of paresthesia at the length of the upper extremity. They are side effects of the problem. It's okay. We can work on there. But the most important ambition for any kind of the fracture is try to keep the stability, try to improve it, try to repair it, and then try to repair the other actually side effects you may come from. Okay, everything is fine. I'm asking you, please. I'm not sure. Is there anybody who record my voice or no? Yes. Okay. Please record it because it's going to be helpful for you. You can repeat it times by yourself. So please record it. Okay. Any question? No. Piece of cake. Piece of cake. Just initial as part of piece of cake. Okay. So the humerus fracture, upper end fracture of cervical neck. We know that there is a cervical neck on humerus bone, you see that, and there is upper third of the body of the humerus, you can see that. And when we are looking on the upper end of the humerus, it can be exactly like the fracture of the scapula. They are similar, because all of them are similar area, are located in a similar area. What does that mean? That means actually the after the whole general idea or goals, I mean the location, stability, immobilization, being confident about the alignment of the bone. After reaching that, of any of them, the scapula or upper end of the humerus. So okay, after that, you have a kind of similarity in your physio program or any kind of limitation you may come from. So abduction, adduction, anything else. Okay, so the worst action that can affect the immobilization, the stability, the worst the range of motion, the worst movement can actually decrease risk of stability is worst movement. We talked about that yesterday. Adduction, external rotation. If you do that, you are in danger of immobilization. Mobilization and danger of non-union or delay. Okay, so that's a great talk. And there are lots of actually methods. You can see it for the humerus, upper end fracture. You can see that, okay? This is a kind of, what was that? It's intermedullary nape, right?
No.
Wrong. What is the name?
Compression blade? Compression.
Not really compression. Doesn't look like compression. It's easy, normal plate and a screw. And so let me see, what was the role of the screws? At most 20% of width of the screw must be 20% of width of bone. So is it good? I think so. It's approximately 20%. Do you remember? So if it's going to be bigger, what is happening? Risk of refracture. Risk of refracture, because it's going to be a kind of instability. So, and there is another term, we talk about that. Total of the screws, I mean the width of screws, must be equal at most to the width of the body of the bone. So 1, 2, 3, 4, 5, 6, 7. So if it's 10 millimeter, I mean the width of the bone. So, and if it's 2 millimeter, you have 7, the total going to be 14. So what is the reason? What is actually the result? The risk of the refracture is a little higher than normal. Did you get my meaning? Should I repeat it again, or you got the point?
Yes, repeat.
You got the point. Repeat again?
Yes.
Okay, there are two rules for any kind of the fracture. First, the width of any screw must be at most 20% of width of the bone. Clear?
Yes.
Okay, the second rule, the total width of the screws, total width, must be at most equal to width of the bone. So, if the width of the bone is 1 centimeter, 10 millimeter, okay? So, and if each of them is 2 millimeter, you can use at most 5 actually a screw, right? 5 multiplied 2, going to be 10 millimeter is equal to 1 centimeter, right? There are 7 screws, not 5. So it shows that the risk of instability is a little higher. So that means it can be refracture with as much simple or simplest force. So the risk of refracture is high. What does change? You get the point, right? What does change in your approach as a clinician? Okay, so I know that the risk of refracture is a little higher. So I don't force the patient. Make it a little delay. There is no 1 + 1 = 2. In no way in the medicine and the physio, anything. Okay, I know the whole structure. I know the concept. I know the science. I know the background. I know the result, manifestation, anything. But I'm flexible to work with this knowledge. Okay, the risk of the refracture is a little high. Okay, I make it a little slower. Make my approach a little slower. Okay, might be 2 days, 3 days, 4 days later. Because I don't want a refracture. If you have a kind of refracture, what's happening? Everything can be from the start. Very worse. Because the surgeon come to the area, bring it out, and then you have to wait for a while, and then put another device. Everything gonna be worse. So, gradually and confidently, you must work with the patient. Gradually and confidently. You must know the physiopathy, you must know the whole of the framework, but it's not 1 + 1. You must be able to afford to be flexible about some data. You know everything, but you're flexible to move a little forward or a little backward. How can you make faster? Is it possible? Yes, somehow. Might be you are working with an athlete, professional athlete, lots of muscle. Okay. If everything gonna be okay, you can be a little faster based on the knowledge you got through the evaluation or picture or X-ray, not based on the your choice or your preference. Yeah, because of the knowledge you can get a decision. Okay, so why the surgeon used 7 screw? I don't know. Probably he cannot provide stability with 5. Probably he has to. It's not a choice to tell to the patient, okay, this is a wrong action. No, you don't know. You don't know that. Not tell to the patient. If you do that, you will start a kind of war. We are closing. We are living in a war area. You are starting a kind of war. You are starting a kind of struggle. He or she, I mean your patient, come back to the physician surgeon and said that, okay, my physio doctor said that you are not actually good surgeon, something like that. Don't do that. Just got the information, keep it on your mind. You can sometimes talk with the doctor, hello doctor, it's okay. I saw that there is a kind of, what is your actually, what was the reason you do this in this way, not in a kind of harsh way, no. Can you please explain something that I can do my job better? Everything is fine. Is it stable right now? Is it okay right now? What is he saying? He confidently say that yes, everything is fine. So you know the answer. It's no need to do that. Perfect, fine. You can start whatever you want. Don't need to do that. Do your job. But be a little slower, be a little actually, how can I say? A little not professional, a little conservative. Be a little conservative. That means keep caution about the situation. Step by step, move very slower. And then, okay. Any question, any ideas? No, everything is fine. So we got a kind of idea that we must repeat all of the type of the ossification. And how many ossification does we have? How many type of bone healing? Mariam, don't say.
2. Cartilage and without cartilage.
Yes, we do have 2 type of the ossification. And actually intramembranous for the cancellous bone, for the epiphyse, and endochondral for the compact bone, or for the diaphysis. And okay, it's based on the tissue of the bone. And you know that the process of the healing, the first one, intramembranous, is a direct ossification, but the amount of the stability is not good because there is no breach cartilage. The second one, the endochondral, you have a kind of mediator, which is cartilage, and it takes a little time, but amount of the stability is great. Okay, so what is the type of the healing in the upper end of the humerus? Is part of the body. It's part of the body. So I don't talk about this item. It's part of the body, body of the bone, I mean. So it's compact bone, it's endochondral for sure. And why you can see some pin here, just 2 points. Just imagine, and you can see also screw here. First, there is a 4 fragment here, 1, 2, 3, 4. So it's not possible to use just a screw or provide a kind of stability just with plate or screw. It's some simple fracture, 2 fragments. You use a screw. But right now, You have 4 fragments. You have to consider or using some other devices. The most easiest one is nail, cow wire or nail. Okay, so you are using nail to keep these parts of the bone together, close together. This is the initial prerequisite for any kind of the fracture healing. Initial prerequisite, immobilization, we need it. Without that, we cannot move. Okay, so mostly they follow, this is initial picture. Mostly it will be followed by some kind of soft tissue injury. You can't see a kind of fracture just in the bone. It's not possible. You are confronting with a human, with a vital body. So you can see probably a kind of injury in muscle, in the tendon, in the ligament, okay. You will learn about the other soft tissue and you will provide a kind of treatment plan for all of the issue, not just for the bone. Okay, that means actually you are considering the stability of the bone, at the same time you are considering about the problem in the muscle, in the tendon, ligament, anything else. And this is the kind of plan, not just specifically for the bone. When you will learn about the tissue, connective tissue, I mean the soft connective tissue in the next actual semester, in physical therapy in orthopedic 2. Somebody asked me, I think, what this is a course of Dr. Feridunia plus Dr. Mir, physical therapy in orthopedic 2, next semester. Okay, good, everything is set. Just one more point, you got it through the picture. One more point, you got it through picture. You see, okay, there are some pin here, okay? There are some pin here. What is the picture saying to you? What is the picture saying to you? It's close to the article line, close to the joint line. What is happening?
Can't move.
You can't expect that you will get full range of motion. So, just you must be curious that how much you can get the range. But if you don't reach the full range, you are not allowed to force it. You know the hold, relax, contract, relax, something like that.
Yeah.
Don't push it. Don't push the joint because it might be a kind of barrier here. So how can you understand the impression or face or voice of your patient? You are planning to provide full range, okay. He's saying, I have a pain, okay, done, relax. It's not a kind of fight. Don't bother it. Keep it. You have a pain, whoop. What will happen? The screw will be broken. Next time again, we'll go into the operation room, going out. The patient will be so happy, but don't do that. Don't do that. Okay, so check the situation of the patient when you are planning a treatment. Be conservative. Again, you know the meaning of conservative? This is the name of party, a political party in North America, conservative, somewhere in England as well. Conservative and labor, conservative. You know the meaning of conservative? Please check it, the meaning through your dictionary. You're so lucky you live in 2024. You can check the meaning very simple. On the time, we have to bring a very huge dictionary with ourselves to check the meaning. We don't need it. Check the meaning, conservative. Is it necessary to write it or not? You know the meaning, no? Use it, conservative. No. Check the meaning, please, and tell the Arabic to the other. Can I check it? What did you write? Write it. You were. No. S. Con S zero.
مريم بالجوجل ابحثي.
Yes.
ما ادري.
S E.
محافظ.
Conservative. Come on.
والله كونسرفتيف. اي محافظ. اي محافظ.
شوي يعني صار.
Party. What is a party? There is no party.